Welcome back, friends, to another episode of the ASAP Pathway podcast. Again, I'm honored to have my partner here with me today, Dr. Tracy. I'm Dr. Stacy, and whenever I can get her from her busy life on with me, I get real excited because I think it just brings so much to the table. The dynamics are different. We've got two minds thinking, and I think it brings out a lot in the conversation. We're really excited today to have our guest, Dr. Stanley Liu. Welcome.
Mhm.
Nice to
Hi.
see both of you, Stacy and Tracy, and now Stanley. We sound like what is this, the K-pop group of 2025?
Yeah, we could be.
I love it. Well,
Yeah,
for
thanks
those,
for having me on. Thank you. Can't wait to
absolutely.
talk to
And
both of
thanks
you.
for taking the time. I mean, you are, speaking of busy people, you're a mover and a shaker. You've got a lot of things happening and you're doing a lot of amazing things. I missed you recently at the Winds of Change in St. Louis. I can't even believe you were here and I didn't get to see you. I wasn't feeling good. And all my heroes in this journey were there. I just was bummed I missed you, but glad I have you today. And for those of you who don't know Stanley Liu, he's amazing. His bio is, we could just talk about it for an hour, all the things he's done, but I'm just going to try to shorten it today so we can dive into some juicy conversations. We kind of were talking ahead of time about what we were going to discuss, and I think we got some fun things to address, much needed topics. Dr. Stanley Liu. He's a leading expert in the field of sleep disordered breathing. After undergraduate studies at Stanford University, he completed dental and medical schools, general surgery internship, and oral and maxillofacial surgery residency at the University of California, San Francisco. In 2014, he completed the sleep surgery fellowship at Stanford University, mentored by Dr. Robert Riley. Dr. Liu's additional training history includes being a Howard Hughes Medical Institute research scholar and a Stanford Biodesign faculty fellow. His tenure at Stanford Medical School spanned a decade, during which he served as associate professor of otolaryngology and fellowship director of sleep surgery. In 2024, he joined Nova Southeastern University as chair of OMFS, assistant dean of hospital affairs, and director of the Breathe and Sleep Wellness Center. He has published over 120 peer-reviewed articles and book chapters. He is a much sought-after speaker at international conferences. And without further ado, friends, let's talk. Let's have a conversation. Tracy, I like your
Welcome,
title,
Stanley. Huh?
Debunking Myths with Stanley Liu.
I know. Well, I mean, I have to commend you, Stanley. I mean, because you were one of the lot of part of the big group that pushed dentistry into dental sleep medicine. You at the Stanford team with Gimeno and Audrey, the evolution of dental's involvement in sleep medicine has been amazing because of you. So I commend you on that.
No,
I
thank
think
you
I
both
hear
very
everybody
much.
clapping in the
Um,
background
Yeah.
listening to this.
So if we're gonna go with our title, like debunking myths, and what I find as a clinician, like, gosh, there's almost too much, there's so much information on the internet that patients are confused on what they need to feel healthy. And one of the big myths that I get a lot, even when patients come into the office, I'll get someone that says, I need is my palate too narrow? I need 44 millimeters. So, like, where does that come from and how relevant is this number? Because I always say, like, I'm not treating to numbers. I'm not treating to numbers as an AHI. I'm not treating to numbers as in, dentistry. We have to look at the body as a whole. So give us a little insight on all of this.
yeah, Tracy, while you mentioned patients, coming in and seeking these numbers, the fact of the matter is, even in academia, if you, let's say, look at the classic papers, let's go back about 30 years, and they're talking about the beginnings of the advancement. So let's talk about at that era, and now it's a board question, which is how much advancement does one need? And the answer is 1 centimeter, right? And that's an academic paper, that's on board exams. Now, you got to stop for a moment and go, well, where? Where are you measuring this 1 centimeter? And gosh, because if it's around the perinasal region, 1 centimeter would be very deleterious to nasal function and aesthetics. If it's at the chin point, it may not even be enough. And that's the thing is, I think for a long, long time, you know, uh, we have been focused on numbers like that because we mistake that as the outcome. We mistake that as the outcome of treatment. And so until we really measure what counts, until we really know what we're measuring, these are the type of things I think that we need to mentor our trainees and advise our patients as they seek care. Because bottom line is they're not wrong in going to you and seeking what they're seeking is better breathing, better occlusion, better function. They don't really know how to say that, so they'll say, okay, based on my research, I think I need this. And
Yeah.
now it's a clinician's job to then say, okay, let's put the story together, and see how we can help you. What is it that you really want?
That's a great point, because a lot of times I'll say like, well, this X millimeters mean different things to different people. And can your body like aesthetically handle that?
Mm.
And then at the same time, I definitely think that we have to kind of get back to like diagnosing what we think is the problem,
Mhm.
and that I don't think we do enough of. We go straight to expansion. We don't look at the AP relationship. And now the latest thing is looking at the joint.
Mm.
How much advancement can you do? And then at what point that will it damage the joint? And
Yeah,
um,
and then not to say all measurements are not meaningful, but it really, as you say, it has to be tagged to let's say a need. Right? When we talk about diagnosis, we're trying to fix a need, and in
Mhm.
that need, what is our understanding of the mechanism of the condition, and measuring exactly that. So I'll give you one I think that does matter. I think it does absolutely matter, although it's hard to measure, but it is important for us to look at the structure and the stability and the function around the internal nasal valve. I do think in a place like that, every millimeter counts. I don't think every millimeter counts in certain other spots that may be measured because it's convenient to measure research wise. As you know, you cannot measure the internal nasal valve conveniently with a scan and all. Yeah, yes, we have published on it, but it's a proxy. We can
mhm.
only approximate. And don't forget, I mean, it's skeletal, it's cartilaginous, it's all kinds of things there. But that one region counts, and so measurements around it does count. But when we talk about measurements, it's not just what you could put a ruler to, right? One of the measurements I think most people miss is I always ask, my colleagues, clinician colleagues go, because they want to publish their findings. And I know they're doing great work. And I say, oh, that's great. Wow, you have hundreds and thousands. You have way more patients than we would ever have in the university. But the problem is they don't measure the patient, meaning they don't measure via questionnaire, a validated questionnaire, the
Yeah.
patient report outcome measure, short of which you really can't publish because all you can publish is before and after numbers. So all you're really doing is publishing CT scans. You're not publishing patient outcomes. So, I think measuring what counts is something that as a field we need to talk more about. And maybe giving a guideline to our colleagues and okay, these are things that really count, and we should do it systematically.
Yeah. Stacy, did you have a question? Because I was
Well,
talking
I
about
get
some of
so excited when someone says nasal valve because it's so under discussed. It's
yeah.
the first point of collapse in the airway, the first point of restriction in the airway.
Is it-
And I think Stanley, you you really nailed it when you said measurements of convenience. Because it's so, especially in the dental world, if all you have is a hammer, everything's a nail, right? So everybody's looking at intermolar width, or they're looking at, maybe a ceph analysis or something. And like you said, it's not that they don't matter, but you have to look at patient outcomes too. And when you have individual compensations, just because one person has an intermolar width of this, or even a tongue tie, someone's compensation might be functioning. They may not need the release. They may be compensating just fine. So it's definitely there's just so many pieces to the puzzle. Like Tracy, you said earlier, there's so much information. And it's so wonderful that we have all this access to information for patients to have autonomy for their own care. But I think at this point right now, it's becoming so overwhelming, um, and they don't know what they need to feel better. We had Courtney Levine on one day, and she said, I mean, there are patients walking in demanding Marpy from her, and she's like, you don't need, but I can't breathe through my nose well. I need Marpy. I need this type of skeletal expansion. But there's
It's
different facets.
amazing how far that has come. I mean, it's not bad. I mean, again, it's
Right.
people patients being aware of all the different ways that we can achieve breathing and wellness. But how do we skip from the era of I can't breathe, so maybe I should go get some nasal sprays and how did we leap right? So
We
and it's
sure
all
did,
good.
didn't
All
we?
these tools are great. Now, Stacey, I do want to and again, I don't mean for this to come off annoying, but I think a terminology that I hear a lot, and not just within clinical realm, but just with data in general. I think what it is we have a lot of data, but data is not information. I think the issue is we have too much data. You can
Hmm.
measure, patients can bring their scans home and measure themselves, but that's not information. Coming to
Well
you
said.
as a clinician and say, well, I'm measuring at 24 millimeters. First of all, you have to figure out where, and then you have to ask why. But again, for that to become information, I think as Tracy was saying earlier, that begins with a past, present, and future. And that begins with a diagnosis, problem, what have we done, and what's next. So anyway, because I mentioned that because we live in a world with way too much data, way
Yeah.
too many apps, way too many trackers, which is all a great thing. But if that thing, unless that thing becomes information, it doesn't help. I mean, I can measure my blood glucose moment to moment, but if it's not going to tell me what causes that spike in an unexpected time, and I have to go figure it out myself, you know what I mean? So there's that translational piece, and I think the modern day clinician, people talk about. I think I have colleagues saying, "Well, AI will replace ortho." So the ortho's features in the AI, and I strongly disagree
Yeah.
because that's data,
Mhm.
but that's not information. And so anyway, so there's that translational piece. Maybe I'm just saying that because we don't want to get replaced by AI, right?
Yeah.
Next year, maybe in a few more years.
Few
But
more years,
yeah,
maybe.
yeah.
Stanley, so I love your the Stanford sleep of surgery protocol where you really break it down by diagnosis. Basically it's like the nose, the tongue, and then so question about like the nose because dentistry's most popular intervention strategy is the nose expansion. So and as we talk about patients that had repeat nasal surgeries, one of your interns did, one of your residents did an amazing article that looked at patients that had um, limited success repeat nasal surgeries, all also had high narrow palates. That's the one, I forgot the guy's name that did
Ryan,
it.
yeah,
Ryan,
Ryan.
yes.
Yeah.
So from a sequencing point, from a sleep surgeon point to an expansion point, who should go first? Given like if you get a patient
Mm.
with repeat nasal, because I find like my patients that had repeat nasal surgeries, sinus surgeries, they are like the worst in responses of non-surgical expansion because like when you're moving everything and everything's already been beaten up, they have the
Mm.
most pain. um do you have any recommendations for those patients? How do you sequence these patients with nasal congestion? Do you do the nose first or do you expansion first if they have a transverse discrepancy?
Yeah. So the sequel, I mean, in an ideal world, right? So
Yeah.
we're talking about in an ideal world, patient comes in, and in the ideal world is the patient telling you that I don't breathe well. And that moment, for from your standpoint, you have to tease out immediately two things. Do you not breathe well when you're awake, and also when you're asleep? All right, because nasal breathing during wakefulness and during sleep are different. right? Their needs and demands are different. So you have to tease them out. And luckily we have, good questionnaires. The nose questionnaire has been a very, very good one. I like the SCHNOS questionnaire, so the SCHNOS questionnaire, which includes the nose, but it also includes 5 questions, I think, or 6, on the cosmetic component of the nose. Okay. And for those of you doing expansions, you will want to have it. Now, this was developed by a former colleague, Dr. Sam Most, facial plastic surgeon, who clearly he wants to, he needs an instrument to measure both the function and the aesthetics, right, at the same time. And that's rhinoplasty. But I think that's quite good to use as well for anything that, we do that may have some anatomic changes. So that's the first piece. You got to figure that out. Then, of course, the history, right? You got to figure out, well, what has the person done for it up to this point? Because you could hear the whole gamut. You can have the ones who go, well, every time I get congested, I go and get Afrin. Ooh, man, how long do you use it for? I don't know, like, 2-3 weeks. You're like, whoa, okay. So, various things, right? You can't get that part of the history. But really, going back to my evaluation or my approach to it is fairly straightforward. If we first focus, so first of all, I always say, for the nasal obstruction during sleep portion, oftentimes you can see that without, putting a scope, without looking inside someone's nose, because very, very frequently mid-facial asymmetry, the side of the face that either grows long or doesn't grow, that side of the nose is always more obstructed. Just the other day, I got a sleep study and I was just looking at it, and the patient favors sleeping on one side. So I said, chances are the patient is obstructed on the other side. And then the orthodontist shows me the photo. And I mean, it's like, I don't know, it couldn't be any more clear. That one. And so anyways, so there's, because not being able to breathe during sleep is a long-term thing. And that leads to changes that you pick up beyond the actual targeted view. Now, when we look at the targeted view, of course, inside the nose, we are looking at the internal nasal valve. You evaluate the septum, right? You evaluate whether it's anterior, posterior, any issues. You evaluate the turbinates. You evaluate the upper lateral cartilage for collapse. You evaluate the mucosa for signs of allergic rhinitis. And then I go to the nasal, the nasal floor. Now, when you talk about treatment for all of this, I think a lot of that really depends on what age that patient goes in. Of course, Tracy, earlier you were saying these are patients who have multiple nasal surgeries. Well, chances are these are, it's almost like a process of elimination. I mean, you've done everything else, and short of some weird manifestation, then you're down to the final piece, which is the nasal floor. And again, the study that Ryan and I did, that's exactly what we had, which was the patients before and after no scores for SNOT scale. And we just noticed that those who were narrower at the internal nasal valve region tended to not feel better breathing after nasal surgery. And the difference wasn't even huge. It was about 6 millimeters at the nasal floor. And then I think about 6 years later, when we did a follow-up, and this was after we looked at outcome from our dome expansions, and we noticed that for those who had a prior septoplasty, who still didn't breathe well, and then we ended up expanding them, actually anything beyond 6 millimeters, they were generally doing better. So we're not talking about a huge change here if we've already addressed everybody else.
Yeah, that's amazing, because I think that's a great study that I reference a lot when I speak. I was like, hey guys, I mean, we're looking at the same patient, just 2 different problems depending on the profession that you're in.
It's just that if the patient goes, a lot of times I think patients themselves go through that process of elimination, right? So I first do this, that didn't work, so then we did that, and that didn't work, so we did the same thing twice. All right, that still doesn't work. So now we go find Tracy and Stacy. I mean, there's that route. But you guys also get the patient who go in and they may not know at all, right? And then it's up to you to say, wait a minute, before we go down this expansion route, or even if the patient does need it, you do want everything else evaluated too, right? Because that changes things. Functionally, that if you're only, say you only did the expansion, the septum still needs to be addressed. The allergic rhinitis is unaddressed. I've seen plenty of expansions where the adenoids are still, by and large in place. I mean, right? You want all of it to be complementary. So,
I have a question on nasal valve because, like I said, I'll do coddle routinely when as I'm referring to an ENT or evaluating a patient for whatever we're doing in the practice. There are different procedures out there, and patients have asked me, in your opinion, which route should I go? There's cartilage grafting, there's the actual, I can't remember the name of the one device that you could actually insert in there, and then there's the Vivere, which is more of like a laser remodeling. Do you have an opinion on if you have a nasal valve collapse or a nasal valve issue, what tends to be the most successful outcomes with treatment?
yeah, I think everything with the airway, I mean, starting from the nose down to the epiglottis, I mean, the upper part of the airway that we address, we always have to think about two things. And that's, there's the collapsibility part of it, right? And then there's the airflow part of it, right? The airflow is going to contribute to the collapsibility. Of course, the collapsibility in itself, innately, the structure being, let's say unsupported, right? Is going to have a propensity to collapse. So it's really a matter of two things. I mean, I can also tell you that we've seen cases where septum's addressed, spreader grafts were done. Everything else is great on a super narrow high arch palate patient. All right, so the person's still going to breathe through with super high, resistance airflow, high speed airflow, and it's still going to lead to collapse. And even if it doesn't do so, which it doesn't, during wakefulness, what happens to that patient asleep? Mouth pops wide open in the patient's
Mm.
mouth breathing. Because when the resistance is so high, you have to go to the path of least resistance. So in trying to tease out or trying to promote nasal breathing, during sleep, you really have to reduce that resistance as much as you can, right? Starting from the nose. And in that case, yeah, you could do any of the above with regards to upper lateral cartilage collapse. But has it slowed down the airflow? Have you corrected sort of that main contributing sort of, I don't know, physio-functional piece to it? So I think
Makes
it
sense.
matters. I mean, I think if you can, it's all on the continuum, right? So if you can somehow by doing, let me put it this way, if a graft works, and whichever graft material it is, doesn't matter. If the graft works, that means that the only problem was the external nasal, the upper lateral cartilage itself. And that's fairly rare. I mean, if this was the only problem, then yeah, any graft would work, right?
Makes sense. Oh,
And,
so
and,
many
and it's true for the
factors.
rest of the airway, right? I mean,
Right,
if the salt palate was the only problem, then your UPPPs will work.
right,
But
right.
that's assuming. Yeah. Oops, sorry. Yeah.
No, you're good. You're
Yeah.
good. Yeah, that makes total sense. So many different factors to look at and weed out. Gosh.
So, like, Stanley, your group, I mean, pretty much, I mean, paved the way for dental intervention strategies with Dome, So, first we were expanding just non-surgically. Then we did the full surgery, which is SARPy. And then we had the introduction of TADS, 5-1 Moon. And then what happened was some cases that didn't work, and then you introduce Dome, right, with the less surgical cuts. What I'm seeing lately is this push for no surgical cuts at all.
Mm.
So from a surgery aspect, how predictable is that? And what are because when I tell my patients, I'll always say, like, look, I can do this with 8 TADs. We hope that you're going to open, but I cannot say it's very predictable. And so I'll say that I can say with faith that my surgeon, you will open. So so how do we as dentists help patients determine which way is the right way for them?
I think you just explained the right way. I mean, I think
Yeah,
you
but
answered
is
your
the
own
right
question.
way to say
You figured
predictability?
out. You figured no, but I mean, Tracy, you were in this whole mix right from the beginning,
Yeah.
and you figured this out. This is exactly what happens, right? And you're giving the patient options because in the end, that's a very important piece of the puzzle as well. If the guy is like, well, I'm in no hurry, I'm cool. Give me the 8 TADs and will open, and if it doesn't open, we'll have surgery assist. And it's really because of that. Now we're building a healthy amount of data that we can then, at some point, make it into information and figuring out who needs what, right? And so that's totally fine. And then it is lucky that irregardless, if it doesn't expand, you have surgical assistance there. But I think that part of the process is actually really well worked out. I think people talking about various techniques of doing it, and it don't matter in the end. And that's why, Dome, while it began as a procedure leading to it,
Yeah.
has always been, and that's why it's called what it's called, is because we're just trying to create this morphology. We're trying to create this dome-shaped morphology where maxillary expansion, where there's bone, right, growth, where there's distraction, osteogenesis, and it could be done by a variety of ways. I mean, I don't know. I tell people, right, with the little kids, it's breastfeeding. With even younger kids, is myofunctional therapy. Whatever it takes to get that perfectly nice dome-shaped palate, you do it. Okay, that's the outcome we want. Now, how you get there, I mean, that's just practice. Individual practice preferences. The realities of the ecosystem that supports you. And that's just the process.
But do you feel like I feel like how you do it does matter. So for example, when I'll see someone that goes, "Oh, I expanded with aligners, I expanded with braces, and then I did skeletal." I feel like, but then you can have the same you can have the same results. I feel like how you do it does matter.
Oh,
So like with that, so then why would I guess just because there's so much information that patients are a little bit confused, and even providers, it's hard for us to guide the patient in the right direction. Like, where would a provider recommend? Because we don't have data to show that don't we don't have data that compares the different levels of expansion in terms of sleep quality.
mhm,
We just have data that talks about expansion and sleep quality, but we don't
mhm.
have data to say, well, like, and I think there was one paper that I looked at that looked at SARPI versus DOME versus MSC, but since then we haven't had anything else. Can you comment on
Yeah.
like the three?
Well, it goes back to a little bit to what we were talking about at the beginning of our chat here, which is, measuring what counts. I mean, so here's the thing. First of all, I agree with you, Tracy. How you do it matters. But what I meant earlier was, what matters is getting to that shape, and also, right, if that translates to good function. So, as long as you get there, how you get there, it doesn't matter. But of course, a lot
Yes.
of techniques or a lot of approaches don't get us there. So what is this there? What is that destination?
Mhm.
Well, what we don't have, although I will say that the Dome papers does have, it built in a little bit of it, which was the pre and post treatment no score, but the
Yep.
pre and post treatment sleepiness score. I mean, what we really need, is before we even get to comparing the various techniques and measuring, different levels, is what is getting patients the outcome they want. So what they want is, I mean, they may think what they want is the however millimeters expansion. What they really want is to sleep great and breathe
Mhm.
great while sleeping
Yes.
and wake up feeling great, which is actually a very tall demand. I don't know why, the three of us here try to chase that goal. It's so impossible. But backtracking it, right? We need actually more papers that really measure precisely those outcomes, and only from those then can we start, measuring things. So again, going back to what that paper tracing that that you say you liked, that Ryan and I did, we first identified the patients by those who responded to nasal surgery and those who did not respond to nasal surgery. And between those two, we had a hypothesis, but anyways, we ended up measuring the whole palette, and then we kind of zeroed in on where things were different, right? So you really have to begin with, like, did expansion work for these guys? Did expansion not work for these guys? And then really look at why, because a lot of it is also patient related, and not so much technique related, meaning the patient may not have been the right candidate for expansion, or the patient had other issues unaddressed by expander, this part of the treatment process. So there's that piece to tease out. On the technical front, I think the issue is so after all these years, right, 10 plus years of all these techniques, and I always joke about it. I said they're all the same because they're all surgically assisted maxillary expansion. Right? They're all
Mm-hmm.
okay. So what's what we haven't studied, because it's much harder, but we are doing that, is what are the patient factors? To this day, we have no idea. We still don't really understand suture biology, nor do we really can we predict the bone hardness, or how pliable it is. I mean, people go by age, but I mean, that's hardly. And then some people go by gender. I mean, that's hardly very, very precise, right? So there's that piece. And then finally, the physiologic measures. I mean, to me, and this is a hypothesis, what lies in the power of the expansion? I mean, if you look at how much we expand, I mean, it is a very small area. At the end of the day, it's a couple of millimeters at the nasal floor if you're successful, right? But why is the outcome, the effect on nasal breathing so profound? And then I've seen explanations that a lot of surgeons like to say, well, you expand it so the airway widens. I mean, it doesn't work like that. Okay. It's not like that. And it's certainly not 1-for-1. And actually, if it's 1-for-1, we're dead because a few millimeters is not really a whole lot.
Yeah.
But what it is it's the physiology. When you do expansion, what you're getting a lot of is nasal mucosa, right? That's the piece that is really, I think, truly magical. When you do dental alveolar expansion, it's not just an anatomic issue. You're not getting nasal floor expansion. You're not getting nasal mucosa. The total surface area of your nasal mucosa is not increased in dental alveolar expansion. Zero. Okay. When you expand into the nasal maxillary region and you have that true intranasal expansion, you have more nasal mucosa. And that is what senses airflow. That is what the things that tells the rest of your body what to do when you're sleeping, lying supine, and nasally breathing. And that's what's really, where the magic is. And so we still need to focus on individual patient biology when it comes to the bone. And then we really need to look at, well, when we do the expansion, I mean, how much nasal mucosa are we getting and what kind of physiologic effects are we getting from that? Then we can not then work backwards again. So I think, so I think, the next 10 years, the more exciting work to look at is really understanding, like, why is this uniquely so powerful? I mean, we are talking about it because it has helped so many patients, but why, And I think we're getting closer. I think we're getting much closer.
I mean, I think that's a huge, great point. I mean, like, Stacey, we got to bookmark that whole explanation with
Yes.
the influence
With
of the mucosa.
yes.
Because it's great that we have to talk about, because there's so many ways to get to the final result, but I feel like how you get there definitely does matter. Stacey,
Yeah, because the real estate here that people aren't talking about is, people talk about expansion, you're getting more bone, you're measuring it on CT. But okay, but what's really happening here, right? It's not like the hole's bigger and so you breathe better. I mean, if it'd almost be nice if
If it was
if
that
that was the
simple.
explanation.
Yeah.
But I have a simple argument for you. Empty nose syndrome has the biggest hole you can look
That's
into.
exactly right.
And the person doesn't feel like
100%.
they're breathing. Why? Because there's not enough nasal mucosa to
Mucosa.
feel like they're breathing. And it's to do what the nose is supposed to do. Or what's the treatment for an empty nose syndrome? You stick in an implant to remake an inferior turbinate.
Yeah.
Okay. But what really is missing when you carve too much structure from the nose is you've lost all the nasal mucosa. Now, if you think about it, I mean, that's, the body is the only thing that you can reliably use to make your own nasal mucosa, right? It's not like we can make it in a dish and transplant it in there, right? So I think that's really where, when we look at maxillary expansion and people are measuring all these things, we have to have a way to see what that nasal mucosa is doing. And in having this extra real estate, this extra surface area of nasal mucosa, is that translating really to the good function that we're seeing in the airway? I think it is. I mean, that's a focus of my research work this year and next. And because I like to kind of look at things that sort of folks aren't looking at.
Yeah.
But I think this is very important. I mean, that's the fundamental biology of the whole thing.
Something I wanted to talk about too is when we're talking about if it was just as simple as just increasing volume, and we all know that sometimes you can make an airway bigger and it doesn't necessarily function better, or it does for a little while, and then you get a relapse or a resurgence of symptoms. So maybe it was necessary, it was a piece of the puzzle, but like, tonsil and adenoid removal, it's a piece of the puzzle, but then sometimes we see symptoms emerge again, or you might have some possible resurgence of symptoms after MMA. But to your point with, just because we've made some changes in the nose, we don't always know what it is that is making the change and how we get the long-term improvement. There was something I was reading about when you make changes to bony structures versus soft tissue structures, how, what we're finding is, and this may have changed, but when you do change some of the soft tissue, you can see some symptom changes, but when you change some of the long-standing bony changes, you don't always see some of those improvements, and it could be related to possibly the sympathetic tone and how things have gotten just kind of used to it. Are they looking at that at all with, okay, you've had this so long standing, is your autonomic nervous system now regulated and based on that prior hard structure? And you might see some changes at first, but then your autonomic nervous system kind of goes back and resets to kind of where it was operating before. Is that a piece of this?
You're asking Tracy that question, right? um, I will say that and Stacey, I agree with I know what you're saying there, and um, when you do the issue is, yes, we need to study this longitudinally, and we need to look, track this continually. Up until now, we've really never had ways of doing it. Now, if you are wearing trackers and you're looking at, I don't know, if your tracker's doing heart rate variability, or you're able to track a lot of data, and that, we're able to then look at things over time, then I think we can, more, we can really show what you're referring to. Otherwise, there are efforts around what you're saying, but all we can do is look at it at a cross section. So you're defining a longitudinal problem, but it's so hard to study longitudinally.
Right.
So then the way we study it is by cross section. So at best, we can say, I agree with what you're saying. Here's the best of what I can share with you on that. But here it is. I mean, I'll tell you on a more simpler level than what you're referring to, because you're talking about ultimately the interplay between anatomy and function,
Yes.
and physiology long term. But even if you just look at interplay within anatomy, within the bony and muscular change, okay, changing one affecting the other, doing some, even that, which is a little bit easier to study, but it hasn't been a focus. I still don't think there's enough of a focus there. Best example, I think you raised, being that, okay, well, remove the tonsils, symptoms return. Well, here's the thing, right? If you remove tonsils in someone who's 12, that's 12 years of large tonsils. It's highly unlikely that that person only has the tonsils as being the only issue. Chances are that person also has a narrow high arch palate and
Yes.
all
Yes.
the anatomic signs that accompany large tonsils, in the body for a long time. So it's and which is also why around that age, probably the best thing to do is to quickly go for expansion, because those tonsils can come out anytime. But that expansion, if you wait any longer, now you're dealing with, more and more and more tabs and everything else.
Yeah,
Right.
we were losing that window
So,
of opportunity when we started approaching that 12. I have a question too, maybe just to explain to the audience. I get this question a lot because I ask patients, how do you feel you breathe through your nose? And they'll say, well, I feel I could do fine, but the second I lay down, I cannot breathe well through my nose. And I tell them, well, I mean, that is a thing. We know that when you are supine, you can have a change in fluid dynamics and all these different things, and then you develop nasal congestion. What is going on with the supine position and nasal congestion? How can you combat it? Can you combat it? Um, what is happening physiologically with that?
A lot of things, the also the phenomenon of nasal cycle itself, just the natural, cycle of the nasal mucosa swelling and, deswelling. We've seen that during sleep. You can have nasal cycle changes. For example, when someone bounces in and out of REM sleep, we certainly see it, in positional changes, as such. Um, I mean, I can tell you practical tips that you could do to kind of to tease out whether it's just a short term or let's say, let's say if it's just, allergies or just nasal mucosa swelling. I mean, you can, for those that haven't tried, I guess, nasal sprays, or even if you want to experiment, briefly, just for a day or two, not long term, try Afrin, and then lie down and see if the same thing happens. Wear those nasal valve supports, those nice whether it's nasal aid or mute or something, just experiment. But don't forget that when you are in a supine position, especially during sleep, if you can nasally breathe, it is supposed to kick. I mean, it is supposed to, activate the dilator muscles, including the genioglossus, to get the tongue out of the way. Right. So that's the other issue too, is you also have the downstream stuff that has to be
Yes.
open for you to continually breathe through the nose. It is an old paper. What I'll do too is I'll send it to you all, and then you can share it with the audience because it's very fascinating. Before the era where it was more big pharma, big CPAP, big whatever treatment, people knew about sleep disorder breathing, but people were trying to find solutions. And so at that time, there was more focus on the mechanisms of the disease or the condition. Anyway, so back then they actually did do very nice studies showing once in a supine position, nasal breathing versus mouth breathing, nasal breathing activates the dilator muscles of the airway, but mouth breathing doesn't. Very important study,
That is
actually.
very,
I
very.
forget about it because after CPAP becomes the answer, after full phase CPAP becomes the answer, that kind of study becomes irrelevant, right? Air's
Right.
going through. But even with CPAP, don't forget though, guys, even with CPAP air going through the nose is so much better than CPAP air, going through the whole face, including the mouth. I mean, it's just,
And I find in my patients that come to me that are CPAP intolerant and they have these full face masks or even nasal, and I just don't know when they're picking up their CPAP if those discussions are happening of, can you breathe through your nose? I mean, it's just here's sometimes they're just being fit for a mask. They're just being fit with this. And the most crucial question for these patients with sleep disordered breathing, can you breathe through your nose? And they're like, no one's ever asked me that. And
but
they're it
what's funny though, if you think about it, right? So when you do the CPAP thing, it's like this, right? It's like, there's some leak, there's some issue. So we're gonna go from nasal pillow to this other pillow to this other strap to this nasal mask to another mask. But if we're not careful, that's not very different than our approach to maxillary expansion. Well,
Mhm.
then maybe we should try this expander, try that expander. We should do this TAD and that TAD.
Well said.
Patient needed. You fix other things, other reasons for nasal obstruction. Are two big honking tonsils? You want to get rid of that, or patient has a BMI of 40. You want to address that. You know what I mean? So if we're not careful, it's now this is not meant. I mean, it's not. We all want to do something right for the patient. I mean, we
Right.
we we want to say, hey, no, 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 try this. Oh, no, 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 we got this. Oh, this one didn't work. We'll try that. But again, that's assume, of course. Let's say that it's for CPAP, or if you have central apneas, or you are, the perfect CPAP patient, and we need all that. But like you're saying, should check with the patient. Can they normally comfortably breathe through the nose? In the same token, when we do our expansions, I think, before fitting them for all kinds of different expanders, we gotta make sure they're the right candidate.
And we have some really exhausted patients and exhausted parents out there that just feel like they're falling through the cracks and they're trying everything and am so grateful for these discussions. And we know where we've been and we've come far. But where do you kind of see us going? Like, where are some of the next steps? Where do you see the research taking us in the next year, 2 years, 5 years?
That sounds like a Tracy question again.
Yeah, Tracy, can you
Well, no,
answer
this
that?
is for all of us. I mean, I love to hear your opinions too on what's, and I'll say one thing. I mean, for the type of effort that ASAP pathway, and what you guys are doing, um, I think if there is a way to have less misinformation,
Mm.
boy, I mean,
Yes.
we've studied this enough. We've done this enough for about a decade now, where we don't have all the answers, but we have some better ones than not, and these better ones need to be there. Just the other day, because I was talking to some Web 3.0 investors, and we're just kind of thinking about healthcare, social change in the next, whatever era. But one of the things, if you think about today, right, social media or the media that we have, I mean, it's fairly primitive in a sense that it's all about view counts. It's all about how many people watch something and then you're rewarded for it, right? I guess if you get a lot of hits on YouTube, you get paid for it or something like that. But then that just drives information that is either sensational at the moment or just stuff that people want to go see, but it may not be correct and it may not be very valuable. So again, my hope is resources like ASAP. You guys are able to pump out very good teaching material, and that does evolve. But I think we really need something for the misinformation out there.
Well
Yeah, I mean,
said.
I think
There's a
there's
lot.
like, yeah, there is. And I think it's, you take one study and then like you make several assumptions about that one study, or that's what I'm seeing. And then there's a lot of pushing of products direct to consumers. And I think
Oh,
that's where it gets a little bit tricky and harder for us to like help our patients.
Mhm.
What's the right way? There's not enough of like comprehensive care.
Mhm.
But
But at the same time, through media channels like this, right, you guys are able to get
yeah.
this out there. And so, I don't know, some kind of little summaries, every so once in a while that you can do. And, again, not everybody's going to love it, but those who think this is very, very reasonable, very good advice, they'll come back to your website, your and update things from time to time for both clinicians, and patients alike. I think that would be really nice. And I think overall as a field, I think focusing on measuring what counts, okay, and that really begins with really at the end of the day, it goes back to the very basics, and that is the patient's outcome, or measures before and after, starting with that, and then from there, use the wealth of the CT and the data that we have to get information. Because right now, what we're doing is just taking all that data and measuring. So, clinicians will come out and say, well, after my treatment, after my wonderful treatment, we increased this length by how much?
Yeah.
And the intranasal volume is by how much? And then the CFD is by how much? By the way, I'm
mhm.
making fun of myself. I did all that. But okay, you could do all that. All right. But all right, you gotta know like who improved. Okay. You have
Right.
to know, did that relate to improvement? So you really have to start with that, right? So starting with who improved, who didn't, and then work backwards. And now all those data does matter. But instead, otherwise, if you're just, doing, yes, it's very significantly different, right? Before and after. Well, no, I mean, what does that translate to? So I think also in the near future, if we can focus on all of us collecting validated questionnaires, and I say validated because questionnaires are, we can all create our own questionnaires, and
Yes.
they may even be better for our patients, and you do that, but you have to include a validated questionnaire that's validated in this country and that country and everywhere else, so we can communicate. When you talk about the nose score and the ENT surgeon talks about the nose score, you actually have something to go to start with. Well, when after the patient saw me, they still put their no score, maybe that question number 2 about sleep breathing, they still rated very high. Okay, and then you get that, and then you're trying to work things out, so you can actually now communicate about the patient in a similar way, because otherwise you're talking about some millimeters of skeletal measurement and they're talking about what they see on the scope. That's okay. That's all good. That's all good data. It's just not information. So we start with the patient's response, and then we begin the discussion from there. So
That's
I
a great point. I mean,
Hmm.
because at ASAP, we're really big on using that. We're very big on metrics.
mhm.
We're very big on like, okay, what's your diagnosis? What exactly are you treating? And what's your metrics for success?
Right.
And so it's like because I think too many times, like we do, and I see it on the platforms that you show before and after of an arch. You're like, isn't this great? I was like, yeah, if our metrics of success is orthodontics and braces, like, so what is because just showing two arch forms doesn't correlate to function. So you have to have some kind of, even as a simple questionnaire, metrics of success that can correlate to function. But yeah, when we were talking about changing the nasal mucosa, like I totally feel like I can, in some patients, I don't get that much expansion. I just probably get maybe about 2 to 3 millimeters, but their function change
Mhm.
astronomically, and so that's where like I've found, and what I tell my patients, it's not about how many millimeters I can get you. It's about how many millimeters do you need to
Do
function.
you need? Yes.
Yeah, and so,
No.
I mean, Stanley, I can talk to you for forever, but I won't
I talk
take
to you
your
guys
time.
forever.
And when are
Well,
we getting him on the monthly members meeting? I mean, gosh, because I think the information has changed so much in the last 5 years. You mean like we're talking about like we didn't have any evolution in dental sleep medicine in the 80s, probably not even in the 90s to
90s. Yeah,
2010.
not
Like
much.
it wasn't until probably 2000. I would argue and say it wasn't 2015 and on did we really hit it aggressively like, hey guys, this is what the data, this is what you guys are reading, but this is what you're not reading that it's actually saying. And this is where the research should be at. So it's amazing to watch
It's
it.
really the last 5 years. I would agree with you. I mean, the explosion of which is
Yeah.
it's out. It's yeah, it's profound. It's
Well,
profound.
and I think the future is more collaboration, for sure. And it's been so lacking. And we've compartmentalized the body, and we got to start all communicating more. And I think that's coming as the research emerges that we all need each other and
Mhm.
that we can fix this part or we can address this part, but this part needs to be addressed. And we have a lot of unraveling. And I think, especially in the dental world, a lot of people are looking for cookie cutter. What are we going to do that's going to fix this entire patient's entire sleep? And sleep is so multifaceted. It's complex, as you said, just getting that perfect, beautiful night's sleep. So many things have to happen in this beautiful symphony of things to have this beautiful night of sleep. Anatomy and function and structure matters. And we're learning more that gut health, neurology, they're all linked. And we have a pretty sick society here. Our kids are not eating well, their diets are off, and we've got poor gut health and inflammation and poor growth and development ensues. So I think we're getting there. I think, but the more we talk and do things like this, and thank you so much for being here today to have this conversation. And um, I think we're taking steps in the right direction. We really are. We just have to keep collaborating and talking. And like you said, sometimes there's more value in uh, busting and debunking the myths and the misinformation that's out there because it's taking people in such a wrong direction or a misleading direction. So it's just as important to talk about what isn't working or what we should maybe look away from and focus more on. So before I let you go, I got to
Let me,
ask
Stacey,
my,
I
yeah,
want one
no, no,
quick
no,
thing,
please,
which is
please, please.
because I fully agree with what you said about collaboration. And I want to, for as a field, let's say at least with obstructive sleep apnea is concerned, it really is the dentist that drove the emphasis back to nasal breathing. And I think that, that ought to be recognized. I'll give you a very good example. 2018, I was on stage with some real gurus, real giants in the field. And the question is, does treating the nose matter for sleep apnea? And everybody said no. Because the data shows that doing nasal surgery doesn't change the AHI.
Right.
Well, yeah, that's cool if the only thing you're looking at is the AHI. Of course, treating the nose by in itself is not going to change the AHI, but you can change everything. So that was the thinking, right? So for the early part of this, all of the surgical concerns were in the hypopharynx, what they call the hypopharynx, which is really, tongue, side lateral pharyngeal walls and all that. And really, it's actually the dentists with the expansion talk drove the field back and say, yeah, but if you can breathe through the nose, that's the sort of where it all starts.
Yeah.
And you can't, so you have to look at the whole thing back again. So all I'm saying is, the tremendous value sometimes with collaboration is just to, we debunked, one of those major myths, right? That nasal breathing don't matter when it comes to sleep apnea treatment. Well, yeah, if you're only measuring the AHI and your only measure of success is whether you have, reduced that AHI down to less than 20 or less than 50% of wherever you started if it's less than 20, right? So fascinating. It's just, when you're my age, you'll see a lot of these historical turns that are just so fascinating. And yeah, hopefully beginning with debunking myths, and one of the best ways to do it is collaboration. Anyway, that was just a fun.
That was a pearl thrown in at the very end. Way to bring that at the end. I love it. No, so true. And sometimes, some of the most interesting and research changing things can come from where you don't expect it, and where you're not expecting that, which, no one would expect dentistry to be talking about the nose as much as they are, but here we are.
I always joke nowadays too. I'm like, okay, beyond like who are the nasal surgeons, or who are the rhinologists for kids?
Oh, wow.
Right? It's the dentist, right?
Yeah.
Look, yeah, you treat allergies and all,
Pretty
but
much.
you're not going to operate inside the nose. And if they're really so constricted and you're going to think about expansion, so the only person that's going to change a child's ability to breathe,
Mm.
in that kind of a big, profound anatomic way, are your dentists. Those who are willing to do it. Those who are willing to treat the kids. So now if you think about that, right? Because is there anything surgical to do for little kids?
Right.
For a routine that, no, right?
Shoot, I just think we found another soundbite, Tracy. That was a good one.
You did. We have to
It's true. Yeah.
Yeah.
I love that. I really have never heard it put that way. Well said.
You try to debunk that one then, because I haven't been able to. I can't argue against that one. I can't.
Well,
What else can be done to change? Anatomy, if they need to, right?
Right.
And again, you're a lot of times you're doing it for malocclusion and whatnot, but you have changed. You have fundamentally changed in a very profound way, right? For these kids that nobody else can. So that's, I don't know. I should go back to doing pediatric. Actually, all of this is pediatrics.
Well, it's funny because like we always get a lot of comments on our chats about like how the ENT they're having a difficult time getting an ENT to get on board. And so the first thing I say, well, let me ask this: what are you asking the ENT to do? Because like the ENT might not be able to do what you think they're supposed to do. Like you can't just say. So I say, well, the ENTs in their wheelhouse is tonsils and adenoids. Once tonsils and adenoids are gone, what are they going to do with the child? Maybe turbinate reduction, but they're not going to be aggressive about that. What else can they do? Corticosteroids. And so I was like, well, what else can they do? So then what do you need the ENT for? Really just management, just to management, any side effects, but then you really are the only one that can deal with the face.
Yeah.
So like as dentists, we really should embrace that. It's like, so, it's funny because we talk about collaborative care and what we need other people, but then we also reduce our own significance in the treatment.
It's so true. Like, that is so interesting.
Like it's like,
yeah.
hey, you have a sick child and you're asking for the ENT to help, but yet you don't show me any pictures of the child. So what can you do? And that's what we try to teach at ASAP. It's like we're equally, we deserve a seat at that table,
Yes,
especially for pediatrics.
especially for pediatrics. So much influence can just change the trajectory if you insert yourself in their growth and development changes at a young age. You can just change so much. And I love what Tracy says too a lot. Sometimes you just need to, I think, I don't know if it's the culture of dental school where, you've been so kind of beat down while you're in dental school and you get out and you're like, oh, just what can little old me do, But it's empowering and really we're more oral physicians. We really are. And understanding the impact you can have. And like Tracy said, do dentistry. You're a dentist. You don't need permission to do what you've been trained to do. Get in there. If nobody's
Yeah.
doing anything and they need the expansion, get in there and make room for that tongue. And let's see what happens after that. So don't be afraid and to sit at the table and be a dentist. We're needed. We're totally needed. Okay, I'm gonna wrap up with our
Rapid
three
fire,
rapid
right?
fire questions. Here we go. What is your favorite music genre or artist?
Oh, I've been playing the drums lately. Been doing a lot of grunge. Been doing a lot of Pearl Jam. Been doing you know,
Really?
You're a drummer?
a beginner drummer. But
I
but I mean
love it.
that's the era of music that yeah.
Perfect. I love it. Okay. Cat or dog person?
Cat,
Or cat.
cat,
You're a cat
cat,
person.
cat 10 times
What?
over.
Okay, you're shocking me. Okay. All right, let's see. What is your morning routine? Last question.
Morning routine. Like cold showers if it's not a cold swim. I like showering outdoors whenever possible. And
Are
these
you
are my
like a
recent
cold
moves.
plunge kind of guy? Are
Mhm,
you,
mhm.
yeah,
Well, no,
okay.
no. True cold plunge is too cold.
Okay,
So it's
okay.
cold-ish. But then again, I live in Florida now, so we were never really cold per se. So
This is
Did
uh,
true.
you move to Florida?
yeah, I'm in South Florida now.
Oh, like where in South Florida? Like Miami?
It's about 20 miles north of Fort Lauderdale.
Oh, I have a place there. Okay, I'm gonna give you a call when I'm in town.
You do that, and I find a lot of my colleagues have houses down there for some reason. But okay,
I mean that's great because I always get people like they're like Tracy, we need you to come down and work somebody up. And I was like, and they're looking for sleep surgeons.
yeah,
That's great.
yeah, yeah. No, but yeah. So, but I do, I mean, the sort of the swim or the cold plunge thing is like this, at least, my current routine, morning routine.
I
Well,
love
it
it.
wakes you up, that's for sure. I've tried it and I'll like turn the
You
shower
like it?
on and it can tolerate it for like a nanosecond. I'm like, woo, I'm out.
Yeah.
My hat goes off to people that can do it. And there's a lot of good health they're showing with the extremes like sauna, cold water, like putting that pressure on this on the human body. It's how we're designed, and our immune systems are tied to that. Our longevity is tied to that. I just like being really comfortable and just operating right in the middle. Well, thank you so much for joining us,
We
Stanley.
Thank
both,
you.
yeah, thank you. Yeah, thanks
Just
for
really
inviting me
appreciate you.
to chat with you guys and then share some of this information.
Absolutely. Thanks, everybody, and we'll see you next time.
Bye.